and welcome to part 2 of this recall discussion of the surgical group of NEET SS 2023. So it has been a very difficult task, not only for you guys when you gave the exam, but also for me to gather the questions, the options, and trying to give you the correct answers. And I understand that in the first part there were some questions which where the stem was not proper, the answer was incorrect. So this can happen because it is 150 questions. You do not remember each and every question in detail. So, and sometimes also the recall is very biased because of something what you've answered, you tend to remember in that way only. So don't worry, you just go through them. If you are watching this recall, then just go through them and see what you have made mistakes, what is correct. If you have any doubt, please reach out to me in the comment section. So starting with the today's session, first of all is the question on Bergsonian bias. So basically it is when you do a study but you do not take a sample from population but you take from a subpopulation. So that is basically what is Bergsonian bias, and in that is not representing the general population. So the answer in this case according to me should be not representing general population. So you do not take, for example, if you are doing a study, you only take the patients or the people in your hospital, you do not take from the community. So if you are taking the study population in the hospital does not mean that it will represent the whole community. Now coming to the eye sign, so this is, I think this has been told to be by the students that this is the image which was asked, and the answer is Dalrymple sign. That is a ream of sclera is visible all around the eye, all around the cornea. Now this is a very straightforward question which was asked, that is bilateral cobra head appearance, that is for bilateral uretrocele. Now best study to know association between risk factor and a disease. So I would say that I had asked this question regarding the studies in our mock test, and this is something from this table from where it has been taken. So if you see the table, there are two things which can be asked, that is it can be cohort or case control, wherein you can study the exposure and the multiple outcomes. Now they asked the best one. So if you see the weakness in both case control and cohort, so the cohort has some potential to establish causal effect, that is the disease occurring to that due to the risk factor, and case control has limited potential. So according to me the answer should be cohort study. But this is something which can be, some of you are telling ecological, but ecological I don't think is the answer. I would suggest that it is mostly cohort study in this case. Now this, what all are the cutaneous manifestations of spinal dysgraphia? We had asked this question in a mock exam. So it will show hemangiomas, hair tuft, dermal sinus tract. So ABC are all correct. The fourth option, which many of you have not been able to recollect, that is the incorrect answer. So these three are correct. So this cannot be the answer in this case because they've asked all except. So in this question, dermal sinus, tuft of hair, and capillary hemangioma are correct. Amoxiclave anaphylaxis with drug is not used. You don't need to go into much detail. Chlorpromazine is an antipsychotic drug, and that is the answer in this case. Okay. Liquid biopsy, identify the true statement. So basically it measures the DNA, ctDNA in the serum, and it can help in identification of the circulating HPV DNA. So basically first of all understand that liquid biopsy is for the ctDNA measurement in the serum, and it can be used in cervical cancer for the HPV DNA measurement. So D is correct according to me in this scenario. Now a young boy, penetrating trauma to left lower chest with cardiac injury, unstable patient. So already the Bailey new edition has corrected that there is no role of pericardiocentesis in a penetrating cardiac or myocardial injury. So in this case with cardiac injury, penetrating injury, the ideal management according to me should be immediate surgery or exploration. You cannot wait and resuscitate for the patient to stabilize because already patient has a penetrating trauma with cardiac injury, so you should go for a bit direct exploration. This image was asked, that is regarding the crossed ectopia, and it is unfused, the both kidneys are separate. I think this is the image which was asked. So in this answer will be a crossed unfused ectopic kidney and not fused. Now Coming to next, that is Limburg. Very easy, very straightforward. It is a rhomboid type of flap which is very commonly used in a pulmonary sinus management. Now breast flap with the lowest abdominal wall, morbidity. So according to what I have discussed with the plastic surgery faculty, the answer is diaphragm in this case, which has the lowest abdominal wall, morbidity, that is deep inferior epigastric artery flap. Okay. NSAIDs are used for cancer prevention, and which cancer it is used predominantly. So I could not find it book, and I've searched the articles, and in that it is given that it is a most promising agent in the chemo prevention of colorectal cancer. So in this case the answer should be colon cancer. Patient coming to a OPD, young patient, blue dot sign. So it is a very straightforward that it is a testicular appendage torsion. Okay. Now Tokyo guidelines, very straightforward. Again, it is used for acute cholecystitis, so nothing much to discuss here. Chest injury with sucking wound, that is an open pneumothorax, so you do not close it. You either put a ICD remote from the wound side and then you close the wound. But if you don't have that in option, then you will go for a three-way plaster closure. That is, you put a dressing and only tape it on the 3 side, keep it open on the 1 side. So that is what you can do as a next step. Other than that, if you have option as ICD with closure of the wound, then that should be the answer. But in this case, that is not given in the option. So the answer is 3-way plaster closure. Old age with end-stage kidney disease, with coronary artery disease, lung metastasis, cholecystitis, sepsis, severe cholecystitis. This is an indication for a tube cholecystostomy. There are very few rare indications where you do a tube cholecystostomy. Other than that, you do not do cholecystostomy even if the patient is having severe cholecystitis, but this patient is having meds, old age, severe comorbidities. So in this case, it is a clinical scenario. So this is a clinical oriented, clinical acumen based question. So in this answer, according to me, should be a tube cholecystostomy. Patient, young boy, hyperparathyroidism, next line of investigation, it should be biochemical. If not given, then you should go for a USG neck to see for the parathyroid localization. You try to identify if there is any abnormality in the neck. You do not do X-ray directly, you do not do PET scan or a DEXA scan. First is biochemical. If not given, then you go for a USG neck. Solitary discrete nodule in a 50-year-old male, CT better than MRI, more risk of malignancy in men, no malignancy risk, USG screening is sufficient. So in this, what I found in this aspirant is that the patients having solitary thyroid nodule in male, they have a higher risk of malignancy. So in this, if the true answer is asked, then it has a more risk of malignancy in men. That should be the answer. Now I'll just again tell you that if you feel that the question is incomplete or the options are incomplete, then please let me know in the comments. I'll definitely answer to you and try to help you reach the correct answer. I am very much being honest that maybe the answer and the question may not match with what you have gone through in the exam, but I've tried my best to gather the accurate recall. If you feel that there is something which you need to correct it, then please let me know in the comment section. Old man with heartburn, regurgitation, UGI endoscopy image was given. This is not the image, it was closely resembling this, which was suggestive of esophagitis with heartburn and regurgitation that may be due to a GERD. So best modality to diagnose this, so either you diagnose a GERD or you diagnose and you need to rule out in the old age with ulcer with esophagitis feature, you need to rule out dysplasia and cancer. Now with esophagitis with heartburn regurgitation, you are almost sure up to a diagnosis of GERD. So next step in this case, you do, if you are doing a UGI scope, you do a biopsy to rule out dysplasia and cancer. After that, you may go ahead with pH monitoring and high resolution manometry, but in this scenario, I would advise for a UGI biopsy. TNMS stage, that is for serum marker, that is a very straightforward question that is used for a testicular cancer. Varicose vein, SFJ incompetence, treated conservatively with compression, heaviness, all are true except, so cyanoacrylate glue does not need post-op compression. you can do in regional, and you do not, you just give the glue and you press the vein, it will be like that. You do not need to give post-operative compression like you need to give in other modalities. So according to me, C should be the answer in this scenario. So moving on to the next question, that is, many of you have not been able to tell me accurately regarding the features which was given, but you told that it was pointing towards pheochromocytoma, and which is true is us. So SDHB mutation is seen. It is less malignant in Men's syndrome. It is MRI is better over CT as per Sebastian and Schwartz what I've gone through. So according to me, the answer should be C, that it secretes calcitonin and PTH related proteins. Now this is an article on which basis I'm telling you that it may be the answer, because sporadic pheochromocytoma may secrete calcitonin and may cause hypercalcemia by non-parathyroid hormone mediated mechanism. So according to me, the answer in this scenario should be C. Coming to next, old age men, edentulous mandible, oral mucosal cancer. It is infiltrating into alveolus, so the answer should be a segmental mandibulectomy. Why not marginal? Why not radiotherapy? Why not observation? Because one, it is oral cavity cancer, which is extension into the alveolus, and it is infiltrating into it. It is not just eroding it. If it was eroding, you can go for a marginal mandibulectomy, but as it is eroding, it is invading, infiltrating into it. According to Bailey and Sebastian, the answer should be a segmental mandibulectomy. Okay, so as you have seen, bone invasion will demand segmental resection of the mandible. Now this annular pancreas, and they've asked regarding the management. So straightforward, duodenostomy is the answer in this case. You cannot do ERCP, you cannot divide the pancreas, you cannot do a RYGJ. Parotid tumor, which is not involving facial nerve, but in the question it is given as squamous cell carcinoma. So remember that squamous cell carcinoma is a high grade malignant tumor in the salivary glands. So you cannot do a conservative parotidectomy. According to me, the answer should be a radical parotidectomy, because even if you feel the literature mentioned in Bailey, Sebastian, Schwartz, and also in the articles have said that even if you need to remove and you cannot go away with resection without removal of the facial nerve, also you should go for a radical parotidectomy, because doing a total conservative in a high grade malignant tumor like SCC will lead to further risk of recurrence. And also, according to all of you, the image was given with a parotid tumor which was almost extending and invading into the skin. That becomes a T4 tumor. So in that case, always the management should be a radical parotidectomy. Now this is something which all of you are discussing, either this was the image or this was the image. Now remember that one tube which is going from outside and it is entering into the bile duct, not entering into the hepatic duct. That means that it is not either percutaneous transhepatic or a PTBD. It should be always T-tube cholangiogram or T-tube cholangiography. It cannot be intra-op, because you can see that it is a post-operative X-ray. It cannot be PTC because it is not going into the hepatic ducts, it is going directly into the bile duct, and it is not a ERCP cholangiography because you are not able to see the endoscope. So the answer in this case should be a T-tube cholangiogram or T-tube cholangiography. Ruben flap not mentioned anywhere where I couldn't find this, but according to the online articles and everything, Ruben flap is basically based on a deep circumflex iliac artery. Okay. Now this is the image which was given to me by many students with some clinical scenario. Now it is obviously very straightforward, pointing towards intussusception. Now which of the following cancer is highest risk in HNPCC? Many of you have told me that there was something that it is not colon cancer, and HNPCC what should be the next cancer, but here it is straightforward that endometrial is the most common extracolonic cancer in patients with HNPCC. So the answer here should be endometrial cancer. Now which of the following feature helps to differentiate between Crohn's and ulcerative colitis? Very straightforward. Skip lesions in Crohn's, granuloma in Crohn's, perineal in Crohn's, and transmural involvement is only seen in Crohn's. So the ABC are incorrect. So here the answer should be D, that is transmural involvement is seen in Crohn's. Now which of the following has high association with rejection? So very straightforward, the answer is HLA-DR according to the Bailey 28th edition, that DR more than B more than A more than C. Now coming to a 4-year-old, inguinal scrotal swelling which increases during the day with no cough impulse, and it should imply that it decreases when the patient is sleeping at night, but it is not reducing on lying down, and it is not having any cough impulse. So that is more in favor of a congenital hydrocele than a congenital hernia. It cannot be a varicocele or epididymitis because it is asymptomatic with only increasing in the day, no cough impulse. So here the answer should be congenital hydrocele. Now this CT scan image with a patulous fish mouth like appearance of the ARCP and the ampulla, which is pointing towards IPMN, and the triad was asked. So the triad in this case is the Ohashi triad. Ohashi triad, that is in ERCP, that is a bulging ampulla with mucin and dilated MPD, which is seen in here in the CT scan. So this answer is Ohashi triad in this scenario. Moving on to next, old patient with CKD, patient not taken dialysis, creatinine is 5, femoral popliteal pulse is present, post-traumatic ulcer is present, non-healing, toe O2 saturation was less than 27. You cannot directly do a CT angiography, creatinine is high, CKD patient, you cannot directly amputate. It is a non-healing, but it is not ischemic or gangrenous, so the amputation is ruled out. The option remaining are CO2 angio and angioplasty or a dressing. Now you need to see that if the ATA, PTA, everything, what is the status of that pulsation, even if you are not able to palpate it. So in this scenario, because of this patient status of CKD, the answer in this case should be a CO2 angiography followed by angioplasty, if at all it is possible. You cannot just do away with dressing without seeing the status of the vessels. So what is the status? So in this case, because of the high creatinine, you should go for a CO2 angiography. Direct question, this has been taken from short. They have taken a lot of questions this time from short, that is what I felt. So CTLI in ischemia, that is the chronic limb ischemia. So what is the feature of ankle pressure and the toe pressure? So they have given two things, that is, one is ischemic rest pain occurs when the ankle pressure is less than 50 or toe pressure is less than 30. But what they mentioned in the next paragraph is that patients with a chronic limb ischemia is suggested when the ankle pressure is less than 70 or the toe pressure is less than 50. So the answer in this case should be ankle pressure less than 70 and a toe pressure less than 50 for this question. Now carotid body tumor 2 cm from the skull base. I think there was a long question stem, but the gist was this: with which of the following is not done? So basically I could not find anything, but I found an article wherein they mentioned that a carotid body tumor which is 2 cm from the skull base, so it is very near to the oropharynx, and you cannot do a nasotracheal intubation because there is a risk of trauma while doing nasotracheal intubation. So in this scenario, you should never do a nasotracheal intubation. You should always go for a tracheostomy. So that is what I found when I searched. I could not find anywhere in our literature, so I needed to go and search the articles, and I found a case report and everything. So this is what I think, that in this case the answer should be nasotracheal intubation is not done, because while doing the maneuvering you may injure the tumor, which is highly vascular. So in this answer should be nasotracheal intubation. Which of the following is true about cardiac transplant? So basically antibody mediated rejection, this is taken from new edition of Bailey and somewhat other sources also, but I could find option B and C. So cell mediated is a T cell mediated rejection, and the donor specific, that is antibody mediated rejection, is confirmed by the presence of circulating donor specific antibodies. So according to me, the true statement in this scenario is antibody mediated rejection is donor antibody specific. Okay. Now according to the Montel classification, A to B to L2, so there are two, either B or C, that is 25-year-old or 30-year-old male with B2L2, so that is colon and stricturing. So the answer in this scenario is very straightforward, that is 25-year-old male with stricture in the colon. Umbilical swelling 10-year-old, gurgling sound, that means it is mostly enterocele, 10-year-old boy, so you should go and operate, you should not wait in this scenario. Jettison access baggage. So the terminology has been changed. Pardon me for the spelling error. So this terminology has been changed from 27th edition to 28th edition in Bailey. So it is given in jettison excess baggage in 27th edition. That means that the cells, the cancer cells, they become more leaner and they become more stronger, leaner. So they lose the normal cellular function. So the answer in this scenario is not immortality, evades apoptosis or ability to angiogenesis, but they become more leaner and they become more stronger, and they are devoid of any other features or any other effect, and they lose the normal cellular function. So in this scenario, the answer is that jettison access baggage is they become excessive and remorseless proliferation, and they lose the normal cellular function. Okay. Now goiter occurs more in female than males. So I found multiple things on the internet that it is sometimes related to the genetic autoimmune disorder, but what I found in the articles is that the presence of estrogen and progesterone receptors, they increase the chances of goitrogenous development of thyroid gland, also leading to cancer in PTC, that is papillary thyroid cancer, in females because of this receptor. So according to me, the answer in this case should be estrogen receptors in thyroid is the reason why goiter occur more in female than in males. Patient 2-year-old, ventricular septal defect, mild pulmonary hypertension, cardiomegaly, QP/QS of 2:1, best management. Now what I found was that if the QP/QS ratio is less than 1.5, that is suggestive of a small defect, you don't need to do surgery. But if they are large defect, that is a QP/QS ratio is more, that is 2:1 or more than 2, then in this scenario you go for a VSD closure. You do not do for a observation anything, you go for a VSD closure in this scenario. Patient with RTA, head injury, elderly male, watery discharge from the nose which is salty in taste, it is pointing towards a CSF rhinorrhea. Now there is a confusion whether it is persistent or not, but if it is, this is the scenario what is asked, then in this scenario you just do observation, you just do conservative management, you do not need to give antibiotics also, that is what Bailey says. So in this scenario I would go for observation. If persistent was given, then in that case you need to do a surgical management, that is beyond 14 days. So in this question, if you have any query, please write down in the comments, so even it is better for us to understand. Now moving on to next, that is a prostatic metastatic bone metastasis in the bone, prostate cancer. What is the management? So we go for a radiopharmaceutical, that is strontium is used in this scenario. Okay. So the answer in this case, with the prostatic cancer metastasis to the bone, you go for a strontium therapy. Now this case where was a perpendicular direction movement of the swelling to mesentery, intraoperatively you go and see that it is a thick walled cyst. What is the ideal management? So that is pointing towards a not chyliolymphatic but enterogenic, and in this scenario you go for excision with a resection of bowel and anastomosis. So in this case answer should be C according to me. Now which is benign cyst? So it is pretty much very easy, 2 cm 3 mitosis per 50 high per fil according to this box given in Sebastian, that is benign, not larger than 2 cm and no more than 5 mitosis per 50 high per fil. So the answer in this case should be C, that is size of 2 cm and 3 mitosis per 50 high per fil. Carbimazole, next investigation should be done. So carbimazole, methimazole, they are all prone to the patient developing granulocytopenia, skin rash, fever, polyarthritis, hepatitis, agranulocytosis and aplastic anemia, for which you need to go forward and see the WBC count. So if the patient is taking carbimazole, develops sore throat, that means that the patient is either having a granulocytosis or the patient may be developing some kind of granulocytopenia. So in this case you should always go for a WBC count. So in this case the answer according to me should be WBC count. So this is all about today's recall session. Now it may be somewhat that the questions and the recall was incomplete, but I've tried to accumulate maximum possible so that I can give you the best recall available. and hopefully everything, all the questions were okay. If you have any doubt or if there is any query related to any question, please reach out to me in the comment or on the WhatsApp. So thank you so much for watching.